considerations. And just as a reminder, what we're sort of doing is progressing through, sort of from healthy aging through end of life with our lectures. So this topic will be covering sort of transitions of care. So if you have questions, you can type them in the chat. We'll cover them later. As usual, we'll have a discussion afterwards. So our presenter today is Dr. Jennifer Drost, Geriatrician at Summa Health. So go ahead, Jen.
All right, let me get this up here and present. And there we go. All right, and forgive any background noise in between. Seeing patients out in the field this morning and this afternoon, so I am in my car in the parking lot, safely parked. No lecturing while driving. So I'm going to go ahead and talk about transitions of care today. And, just starting off, what is a transition? How does that apply to care? So a transition, straight from the dictionary, is the passage from one state, stage, subject, or place to another. So it really can cover quite a lot. And when we talk about transitions, these are some of the transition words that we use. So does anybody want to unmute and maybe use one of these transition words as it applies to providing care or the care of older adults, or you could type it in the chat box.
And could you repeat that, please? I'm sorry.
So when we think about caring for older adults and your experience maybe that you've had, just using one of these words to describe your view of how they transition in care. So I could take one off the top here and say, undoubtedly transitions of care for older adults are complex.
I'll go, Jen. Following transitions of care of older adults is difficult.
Great.
Laura says individually.
Individually, that older adults have a difficult time with this. Because that is true as well. We could say, nonetheless, we all can work together to improve the transitions that older adults face as they move from site of care. So moving on, when we talk about transitional care, then, that is that, transitions of care or transitional care, those are services that are provided typically through a primary care type of setting that are designed to ensure healthcare continuity across those sites and really work to decrease the risk that older adults face along these transitions, or high risk adults. I mean, it's care that applies not only to older adults. And why is so challenging? So this is it is very not exactly the same as we talked about when we talked about our geriatric syndromes. And there are those physiological changes that occur as people get older in the cardiovascular, pulmonary, GI, renal, muscular systems that make acute illness more difficult, but that means also that those transitions can be more difficult. So all of these changes that occur do make older adults more likely to become ill, more likely to face hospitalizations. But these same things that occur also make it more difficult for them to recover. So we kind of put it on a teeter-totter, if you would. For younger adults whose physiologic systems are hopefully optimized, their teeter can totter, or totter can teeter, a lot further before somebody falls off. Whereas an older adult, their ability to flex, to respond to those insults to their system, it gets narrower and narrower. And when you add chronic illnesses or you add geriatric syndromes onto there, that gets even smaller. And again, we see before, all of these geriatrically play together to complicate care. Arrows. Okay. So when we think about transitions, and thinking about that site or that movement from one place to another, we often think of that person is living at home. They come in through the emergency room when something has gone wrong. They've had a fall, they've developed a cough, and perhaps are worried about pneumonia, a heart attack, a stroke, something like that. So they come in urgently into the emergency room, then they're admitted to the hospital. They may or may not go to a post-acute facility or nursing home, rehab facility, or they may do that rehab at home piece. But we think of it kind of in this more linear, or at least one direction of events. When in reality, for a lot of our older adults, it's this mix and match and switch back and forth. So they start at home, hopefully, and maybe they do come in through the emergency room, but at that point in time, it's not, not deemed necessary to admit them to the hospital, so they go back home. But in that transition, or in that process, there really are still two transitions: home to the ED, where risk occurs, and then ED back to home, where there's another set of risk for decline that can occur. But often, particularly for our complex older adults who've got multiple illnesses, they're at home, they come to the emergency room, they get admitted, maybe they get sent home for one reason or another. Maybe they don't do well and come back to the emergency room, or maybe they do well for a while, and then the next, a next illness or injury come up and they wind up back in the emergency room, into the hospital, and then maybe they go to that nursing home. And maybe while they're there, they do have to go back to the emergency room or back to the hospital once or twice, depending on the situation. And each one of these times where a person transitions from one location to another in the health system is a transition of care, and puts that person at increased risk for reasons that we'll talk about as we talk further. So we'll start with that first one, that home to the emergency room. And why is this risky? Well, what is the goal of the emergency room in general? The goal is to identify potentially life-threatening illnesses or injuries and to initiate appropriate treatment interventions rapidly. It's not the end goal, right? The end goal is not the emergency room. They're really just trying to initiate appropriate treatments to stabilize that individual. So we talk about those acute things: a heart attack, a stroke, an acute infection, a car accident or trauma. All of those things need that rapid, quick assessment and intervention. But then it goes on to the next level of care in order to continue that therapy. And the emergency room does this super well. But when we look at why older adults come to the emergency room, certainly it is those acute things, but often it's also, or it is as an alternative, it's because of a lack of social support. It's for falls. It's for general, I don't feel well type of complaints. It's not one of these acute things, but it is a complaint that ties in not only those physiologic changes of aging, the chronic illness, but also those geriatric syndromes. And the emergency room has not been built up until this point to do this well. Older adults are very likely to seek care in the emergency room. Up to 48% of older adults seek their care through the emergency room. They often involve more staff time, and they're much more likely than a younger adult to be hospitalized. So that standard care, again, for patients in the emergency room, they're looking for a single pathologic condition, a heart attack. Boom, I know what to do. It follows this protocol. This is how we stabilize the person. Again, it's that one problem. The scope doesn't really apply to the social problems that might precipitate that hospitalization. Typically, and things are changing, but typically there's really no screening that's done for those social determinants of health, for medication adherence, anything like that. And they're really focused on the medical, not the not the psychological needs of that individual, and certainly that limited interaction with family or the rest of the network that's supporting that individual at home. For frail older adults, and kind of repeating that, so we get that emphasis here, is it's subtle and consecutive failure of multiple organ systems. So it is that physiologic changes, it's a chronic illness that increases the complexity of the care that those need. And we have to really focus on trying not to prematurely close what our differential diagnosis is for that individual. So we're keeping a broad picture that we say, it's not only this, but it's also B, C, D, and E. We need to work on nursing having standardized assessment flows for function, for cognition, for mental and behavioral health things outside of just that acute illness or injury. And we still see those adverse effects that occur in the emergency with adverse drug events, challenges in medication reconciliation, which we'll talk more about as well. And this is all not to say the least about what the actual emergency room environment is. Typically they're crowded, it's loud, there's not a lot of personal space, even in emergency rooms where they do have individual rooms for people. They're often small and crowded. Beds are not comfortable, they're not designed necessarily for people with limited mobility. Might be high up in the air, and so a person's not able to get in and out, further limiting their mobility. People aren't allowed to get up. The bathrooms are down the hallway and around the corner. And that pace of care that occurs in the emergency room certainly is more difficult for that transmission of information, of getting history both from the patient, but then providing that information back to individuals and their families. So these are all of the things really that make it more difficult to care for older adults in the emergency room, and then as we transition into the hospital as well. The comorbidities are often multifactorial. There's a high risk of polypharmacy, taking medications that either interact with other medications, interact with the biologic changes that occur as people get older, interact with each other. There is some limit to the access to care, so those follow-up pieces, especially now, though it's better than when we were in kind of the height of the COVID scenario, but trying to make sure that individuals have access to those follow-up needs, the mobility issues that we talked about, the social support, and limited social support has been phenomenal to see over the last year as people have kind of tightened ranks and wanted to limit the exposure to our frail older adults. How we interact with cognitive impairment certainly becomes important as well. And then those behavioral health pieces. So the emergency room just really hasn't been designed historically to care for older adults. There are efforts now, both through the American Academy of Emergency Medicine or the American Emergency Physicians Academy, ACEP is how it is, but the Emergency Physicians Group, which helps to provide education and support and working to establish geriatric friendly emergency rooms, actually through a certification and criteria process. And some of our local hospitals are doing that, but that could be something certainly if you are in a place that has multiple emergency rooms, of looking for an emergency room that has been designed to be geriatric friendly. I'm going to pause there. Does anybody have any We'll start with good stories. Good stories about care for an older adult that happened in the emergency room and why, not necessarily the medical care, because certainly trust our emergency physicians to provide that acute care. But in those complex situations, what has gone well for somebody that you know?
Go ahead and unmute and speak up if you have an example.
I have an example. My mom, who's 85, had fallen in a parking lot and had a head injury, which resulted in a brain bleed. And, I live in an area where access to healthcare is pretty decent. But the first emergency room I could get her to had to transport her. And I'll have to say that the people who were currently staffing the emergency room that day spoke to her in a respectful manner, treated her like she was, a competent adult, advised her of every step that they were going to take, asked her questions about what level of care she preferred, helped her make decisions based on the information that they currently had available. And it ended up being, a very positive outcome. But compared to some of the other people that I work with, that's not always the case.
Great. Thank you for sharing. Anyone else with a good story?
I will say I had a very similar episode. It was with my mom, and I think one of the most stark differences that I saw in that visit, which was wonderful, when Maureen said they spoke to her, and that meant the world to her, to my mom, because she was a tiny little frail lady, and she was often overlooked. Probably a lot because she has daughters that were nurses, but beyond that, she just oftentimes felt ignored. And I think speaking to her in that environment when she was scared and she was nervous, but that made all the difference in the world. So similar story.
Yeah, I have something. Can everybody hear me okay? Okay. My husband went to the emergency room and, they quickly looked for, okay, what's something going on here that's life-threatening. And what it was is he couldn't move. One side of his face was drooping. Okay, so they had to decide if this was stroke or not. And there were two things they were looking for: stroke and Bell's palsy. And this doctor happened to have I guess she was a student with him, and he was explaining to her what he was checking for to differentiate between Bell's palsy and a stroke. And you know what? I can't remember which was Bell's palsy or which was stroke, but he was asking him to move his eyebrows. If he could move both eyebrows, it was one thing. If he could only move one, or I don't know, it was the other, it was Bell's palsy. And maybe one of you can refresh my memory on that. But I thought that was interesting. I got to observe them, of course, checking my husband. And then the doctor was also teaching the student. And they were treating Jerry very well. And this was at, well, I won't say the hospital, but it wasn't Akron General. But anyway, yeah, I just thought that was interesting. And I just liked the way they handled it, and they were, really killing two birds with one stone. They were teaching at the same time they were still giving full attention to my husband.
Great, great. Yeah, some great examples, and I think all of those really highlight, particularly, I think it sounds like the pace and the communication and how important that is when we are talking about care for older adults. So even those extra few minutes to kind of pause and talk to each individual and get their information, or taking that extra few minutes to explain physical exam findings, certainly can make a big difference. So great. So transitioning then in the hospital, and certainly not everybody who comes into the emergency room has to be admitted to the hospital. Many people do get discharged from the emergency room back to home. But again, that's another transition point. But those who can't be managed as an outpatient should be hospitalized. And again, a lot of good things, and a lot of things, I don't want this to sound disparaging to the healthcare system, because there definitely are reasons that we need to go to the emergency room and we need that treatment. There are reasons that we need to be admitted to the hospital. But for older adults especially, it is certainly a risky time. And we look at headlines for older adults who are admitted to the hospital. They arrive sick and leave disabled, and this isn't uncommon, where people really come into the hospital. Yes, they're facing an acute illness, but prior to that, they were able to dress and bathe and kind of carry on their normal daily activities, and afterwards are needing much more assistance than before, and some people not recovering. So why is that? So this is a super old graphic, and it's super busy, and I don't want anyone to spend time really memorizing it by any means. But this is what Dr. Creditor actually kind of created this graphic in a paper from 1993. So this is showing really all of the effects that prolonged bed rest can have on an individual. So our bodies are not meant to be supine. They're not meant to be flat for prolonged periods of time. We are designed to get up, to change positions. We are designed to move and to walk. And prolonged bed rest then has a lot of potentially negative impacts, not only to our muscle strength, but to our aerobic capacity, our ability for our blood vessels to regulate themselves, to clamp tight when they need to and open up when they need to, which can affect our blood pressure. It affects our ability to breathe, so ventilation appropriately, and being supine for a long time does change the way the blood flows through the lungs as well. It can increase the risk of incontinence. You get alternations in thirst and nutrition, and we'll talk about some more of these. Being supine does affect your skin and increase the, because of the changes in older, as you age in your skin, being supine puts different pressures on it. So you can increase that risk of developing pressure sores or shearing types of forces that increase the risk of again, bed sores, or pressure injury is as how they're referred to at this point in time. And then we often tie people down and not necessarily using restraints, but using catheters or IVs. Those really are tethers and impact mobility. And all of that, as that comes down, really affects that deconditioning. So starting kind of over on the left-hand side here, deconditioning, which leads to increased risk of falling. If you have a higher risk of falls are kind of this never event that everybody's super scared of in the hospital because of rules and regulations that can impact the hospital. So, people who are high risk of falling are told, don't get up, you have to ask for help, you're gonna maybe put physical restraints on you, gonna let you just move over to the chair for a little while. So again, just increasing that risk of falling. We talked about pressure stores already, malnutrition, dehydration, and all of that leading to a lot of functional decline, and the increasing risk of winding up in a nursing home, not only in that post-acute or just after the hospital for therapy, but for long-term care as well. So this is a list that looks familiar from before. We talked about for the emergency room. We're going to talk a little bit more in depth here about it for older adults. Doesn't mind. And so the comorbidities. Most older adults who are admitted to the hospital have multiple chronic illnesses that increase the complexity of care. So somebody with pneumonia, but they have heart or they have diabetes, or they have COPD or dementia. Not only are we working to treat that pneumonia, but those other chronic illnesses likely will need some attention. There's also, often those hospitalizations are multifactorial. So yeah, they came in with a pneumonia, but maybe that pneumonia would have been treatable as an outpatient if it wasn't for the fact that the pneumonia put an increased strain on their heart. And now they also have, a heart failure exacerbation, or, they were struggling to breathe, and they had a fall. And so now they're also fearful of falling, and that's complicating the picture. And so as my refrain becomes, it is this interaction not only between those chronic illnesses, the changes with aging, that acute illness, as well as those geriatric syndromes. We look at medications, and medications are a huge risk for those transitional periods, both at admission to the hospital as well as discharge. And they found that at least 80% of older adults have at least one significant medication problem related to prescribing while they're in the hospital, whether that's because they should be on a medication that wasn't carried on from home, or that there was an old medication list maybe and a medication was stopped and they're started on it again. Risk of interactions. We hold medications when people come into the hospital for all kinds of reasons, but some of those medicines do have a risk of withdrawal if we stop them, and can put people into a delirium type of picture. So that's definitely a high risk situation. There are, and this is a graphic from Sue Fosnider, pharmacist we heard from before also, that medication reconciliation, that process when the person comes into the hospital, that we get a complete and accurate, fingers crossed, hopefully, list of medications that individual is taking. And thinking about, garbage in is garbage out. So if we're not able to get a complete and accurate medication list, because of a whole variety of reasons, our ability to maintain or optimize that list also becomes super challenging. And then that gets carried on into that next transition, which is the discharge from the hospital too. Medications, I'll put in this plug for everybody, keeping a complete and accurate medication list with them, or getting one for your loved one, because it is more than just what was prescribed, right? For all kinds of reasons, people choose to take their medications or not take medications that are prescribed to them. And so it is not just, we can't just call the pharmacy all the time and say this is what they're actually taking, because a medication may have been prescribed that has since been stopped and the pharmacy doesn't get notified of it, or that the individual maybe isn't taking themselves, was changed by another provider. So multiple providers add all of this complexity to that. There are Beers and start-stop criteria, which look at how we address medication interactions and potentially inappropriate prescribing for older adults. And when they look at how medications turn over with people who are admitted to the hospital, there's about a 40% discontinuation rate. So 40% of the medications that you were on when you came into the hospital were stopped, and then 45% new. So slightly more than were stopped, were restarted, but something new. And this can be mild changes in, a dose of a medicine. Say you were on your water pill and that dose was increased, your blood pressure medicine was increased or decreased. So that all counts into that too. But certainly recognizing or making sure that individuals are aware of those changes is real important. Access to care. And again, another thing that's been particularly challenging with COVID is how are older adults able to access care once they are discharged from the hospital. Lots and lots of older adults through the time of COVID, of the COVID pandemic, have opted to minimize their visits to the doctors, to establish new relationships with consultants, and to generally follow up from that hospitalization because of fear of exposure to the virus. So that is a challenge that's unique to the past year or so. But even before that, transportation, communication of those needs, why that information, why that follow-up is important, is often a barrier. If you think about being in the hospital, and if you're in the hospital for 3-5 days, you very well could see I don't know, 10 different medical providers between the physicians, maybe if you're at a teaching hospital, your resident team, if they have, advanced practice providers with nurse practitioners or physician's assistants that are facilitating some of those visits. And so that's real confusing for all of us to kind of wrap our head around who all of these people are and what all the information they're telling us is. We talked a little bit already about this lack of mobility and the focus on safety and falls as a never event. If somebody, just so everyone's aware, if somebody falls in the hospital and has a significant injury, the hospital is financially responsible for the care that person then receives related to that injury in the hospital. So that the most insurance companies won't pay for that. So someone comes in with a heart failure exacerbation, they're a high risk of fall, they get up, they fall, they break their hip. Again, the hospital is responsible for that, surgery and post-operative care while they're there. So it's really treated as this never event, right? There's never an excuse for somebody to fall in the hospital. And really what that results in is a lot of physical and cognitive restraints and we talked about that, either, physically restraining people or, people with IVs and their catheters that prevent them from moving, or, that emphasis on call, don't fall. You'll see signs about that in the hospitals, bands on people's arms that say I'm a fall risk, stars on the door, everything that emphasizes those things are designed to emphasize that this person needs help, but to that individual, maybe saying, it's too high risk. I'm afraid to get up. You're kind of making me afraid to get up. So as a result, they have found that about a third of those in the hospital will be discharged with a new disability. And we know that not getting up, not moving around increases the risk of delirium and increases the risk of pressure injuries. So poor social support also still occurs in the hospital, particularly with our frail older adults when we're talking about discharging individuals with people who have cognitive impairment or their hospitalization has been complicated by delirium. But we also still occasionally, they're really, really resistant, and unless person's in a point of imminent harm, these social admissions are on paper rare, but somebody comes into the hospital with a fall, with this weakness and debility. A lot of times that's much more of a social admission, right? It's the person can't care for themselves anymore, and they don't have the support at home from family, from friends, from hired caregivers in order to be able to continue to live independently. We need a lot of support at discharge and for follow-up in those situations. COVID again limited visitors while they were in the hospital, and we're still working with individuals, and sometimes, as we've heard, individuals don't hold different values. We'll phrase it that way, right? So me as the doctor, or someone as the nurse, or, you know, you as a son or daughter of that individual, really recognize that this is a high risk situation for that person to go back home and to continue to live independently without any additional help at home, right? And so that refusing of those community-based resources to come in, a home health aide, you know, nursing, even physical and occupational therapy, sometimes people refuse because, you know, they're expressing that value for their independence and their privacy. So we might recognize that, and how do we pull in those supports in a way that lets that that individual still retain that control in their life while trying to minimize risk. Frailty increases the risk of hospitalizations, and those who are in the hospital are more likely to become frail. In the literature, this is kind of the definition here on the left. But being in the hospital, again, increases that risk of frailty. So we already talked about 50% have a new onset of disability while they come into the hospital. Obviously, all of this increases the risk of disability and morbidity, which is more illness, and mortality, which is death. Increasing the risk of institutionalization, so transferring from the hospital to a nursing home and winding up residing in that environment. And then just a note on nutrition and malnutrition. So studies have shown about 39% of admissions at the time of admission, 39% of older adults are malnourished, and 25% got worse during the hospitalization. So hospital food, kind of feeding times, you know, onset of confusion and weakness that limit a person's ability to feed themselves, all become difficult. One of my kind of crazy pet peeves is the eating in the hospital bed, right? So you're already at a really poor postural position, and then you slide the tray across the bed and it's about 6 inches too high, and you're seeing the person like trying to eat from up here. That's they're semi-reclined in the bed. It just is a terrible situation to try and encourage people to eat from that position. And then we talk about increasing risk of choking and all that kind of stuff. It is hard. We also think of the hospital environment with the noises and the odors and the people in and out, the time it takes food to get from wherever it is up to the room, and so it's cold. Again, just all of these things that make food like not super appetizing for somebody who's not feeling super great. Older adults also then don't drink as much water. Their thirst perception, because of changes in the kidney and regulation of thirst in general, decreases. Water sometimes is difficult to reach. Again, you got even though they've made the cups smaller, I think they're like half-liter size now instead of a liter size, which they were a couple of years ago. You know, they're still often sitting off to the side of the bed or on the tray, and it's, you know, higher than usual. And so, you know, just again, thinking through those barriers. And then dentures. Dentures, I kind of feel two ways about. I'm kind of happy when families take dentures home from the hospital because they like to wander off, get left on trays and swept out of the room and never found again. But then it also makes eating much more challenging. And cognitive impairment. So obviously, older adults who have cognitive impairment or have dementia at baseline are higher risk of complications while they're in the hospital. Even without a baseline dementia, older adults are up to 60% likely or up to 60% of older adults will develop some form of delirium, which is that acute onset of confusion while they're in the hospital. They may be hyperactive, and those are the ones that we hear about and we know about and we intervene on. So they're restless, they're agitated, they're hyper alert, they're not sleeping through the night, they're trying to get up out of bed. They're the ones the nurses are calling and asking for help in order to manage and protect the individual from harm. But hypoactive delirium is often underappreciated and missed and is more common. And those are folks who are sleeping, all the time, or a little bit more difficult to arouse, maybe, wake up for a short period of time and then go back to sleep, but continue to be confused. Those are the ones that are quiet. They're the kind of ideal patient when people are in the hospital, or for the staff to take care of. But from that standpoint, then also has been associated with worse outcomes because they don't get the, it's not identified, and they don't get the acuity of care to address that. They found that about a third of these things can be prevented by addressing sleep. Immobility, like we talked about already, getting up and moving is super important, making sure people have their glasses and their hearing aids, and trying to encourage hydration as best as possible. Behavioral health concerns and depression and anxiety specifically. So while we know that older adults in the community who are, kind of living their life in the community, major depressive disorder is no more common in them. It is more common in folks who have chronic illness, and those who are hospitalized, and those in nursing homes. And they estimate that up to 10% of hospital admissions are mood disorders or depression and anxiety are implicated in those. So meaning that, it may be related to depression itself. That kind of really goes hand in hand, I think, a lot with the social, psychosocial needs and stressors for that individual. But also, if you think about anxiety, so folks who come into the hospital maybe with shortness of breath, or at least come to the emergency room with shortness of breath. That shortness of breath might not be bad enough that it warrants hospitalization, but because of the anxiety, you kind of get that stacking together. You become real anxious of their shortness of breath and worried about what's going on. So this is, again, another chart from, it's actually from the Geriatric Review Syllabus that kind of looks at all if most if not all of the things that we've already talked about when we're looking at those hazards, and then what are some of the interventions that we can look at to improve an older adult's hospital stay. So thinking through that, definitely making sure that we are getting people up and moving, limiting bed rest for only those who actually require it, but doing physical occupational therapy and getting them up helps with the function, helps limit new onset disability, helps to improve incontinence issues if people are able to more safely maneuver themselves to the toilet on their own, improves the risk of skin breakdown, helps with the cognitive impairment and delirium. So mobility is huge. Nutrition and ensuring that people are getting proper nutrition, getting proper fluid intake with water, definitely helps. And then the medication piece. So if we picked out like kind of three main things to address in here, it's the mobility in my mind. So I'm up for debate if anybody wants to, but the mobility, the cognition and delirium, pharmacy piece, and then the nutrition and fluids. But certainly all of these things are real important to our older adults. So before we go on from there, we talked about good experiences in the emergency room. Does anybody have any examples? Any examples of care that was received in hospitalization that had some room for improvement? And kind of which of these types of things with the older adult do you think really are highlighted?
I have an experience with the hospital I was in it about 10 years ago. I was given the wrong medication, and I kept arguing with them about them giving me the wrong medication. And then they finally said that they were just going to document that I refused But I questioned, what if I was an elderly person that couldn't speak up for myself? Would I just be given whatever they were going to give me?
I'll answer that. So this is Sue Night, pharmacist. So really important to keep an accurate medication list. It's kind of amazing how many times the medication lists that are in the computer are not quite right. So very good point. And yeah, I think that if you weren't there or your family member wasn't there, and if somebody didn't do a very accurate medication history, like calling your pharmacy as well. So sometimes we do catch that because it doesn't make sense that you'd be taking that, but not always.
Right.
I think too, an even bigger challenge is somebody who doesn't speak English or even speak English well. So that I think is a major challenge for them.
Yes, absolutely. We do have translation services, but you're right. Again, just another plug for keeping an accurate medication list is really important in case you have to go to the hospital. For our older patients, just absolutely need that.
And I mean, it's hard. And you look at folks who have, you know, these complicated medication regimens. They're taking, I mean, in my mind, right, if you're taking more than 5 medicines, it's a complicated regimen. But it's not uncommon for folks to be taking 10, 12, you know, different medications, and many of them multiple times a day. And that's hard. And I do house calls medicine. So I'm physically sitting at people's dining room tables. And it is still a challenge sometimes to get all of those medications, to get people to accurately and honestly tell you how they're taking their medications, because everybody knows I'm supposed to take this, but I don't like to take the water pill because it makes me pee all the time. Yeah. So tell me, like, and it's really hard to get that information out of folks. And then right, you try to do that when they're in the hospital and there's all kinds of other crazy stuff going on. Like, it just gets that much worse. So definitely encouraging, again, I mean, just as Sue said, to keep an accurate medication list, to go over it. You know, people pull medication lists out from you know, they were given by their doctor, but it was from 3 years ago, and that's the one they're still pulling out of from their wallet. So yeah, super important point.
And I think, go ahead,
I'm sorry.
Linda.
Also, when they take the medication, for instance, if they have to take something before eating, like levothyroxine or something like that, their breakfast is already sitting there getting cold, and they haven't been given their medication yet. So on that medication list, you know, if something's supposed to be taken before breakfast, that might be a good notation to put on there. Or after, you know, after eating or with food, you know, things like that would be, I think, helpful to the staff and patient.
I agree. That's helpful to know how you take it at home, so we can, a lot of those things are programmed, and when we give them the way they're best, but sometimes it's best to give it the way you've been taking it instead. And I would say Parkinson's disease meds are certainly like that. That's really important to know what time of the day the patient takes those as well. Those are a special class that's important to get right.
Yeah. Yeah. And just
And
a
I
comment.
think,
Oh, I was just going to comment real quick for Mary there, as far as you know, not primary English speaking folks. You're recognizing that, yes, they are, and actually both the hospital as well as individual doctors' offices are required to provide translation services. Oftentimes that's by a phone, which does get a little bit more complicated with older adults sometimes, and hearing issues and those sorts of things. But it is a requirement. And we are not supposed to rely on family in order to do that. So it is supposed to be a trained medical translator. And so if you see patients like that, or if you were in a position, I don't know laws outside of the US, but if you were in a foreign country, right, and being asked to provide that service, or vice versa, you know, if you're in a situation where you're being asked to be the translator and you're not comfortable with it, or want to, you know, make sure people are doing their jobs appropriately, making sure to request that.
Right, and also they never like to have the family member do the interpreting, because it happened to my mother. They would not let me do the interpreting, and there she was at the hospital. I need somebody to talk to her. I think sometimes exceptions should also be made when you have something that is critical and that is, you know, life-threatening. I know it's hard to draw a line, but sometimes you will have to.
Yes, yes. So in an emergency, or you know, to help to facilitate, you know, family conversations, I think all of those things are important. And certainly, you know, asking the individual, if, and both the individual patient as well as the person, family member who would be serving as the translator, if they're comfortable in that role, you know, that definitely giving people that opportunity to express that, you know, would all be good recommendations. We had oh, go ahead,
So
Mary.
Annette, yeah, Annette says that their ED has a pharmacy tech that calls every patient's pharmacy to confirm their med list. It's helped much, and she also says we have a clinical pharmacist in the ED. Says that's an invaluable part of the team. Maggie says also when a medication is being used for something different than typical, like an antibiotic for COPD, not for infection prevention, but rather new research says it helps the lungs. You want to comment on that?
As far as yes, yeah. So there are so from a net standpoint, super helpful to have like pharmacy tech call the emergency or call the pharmacy. Again, that caveat that sometimes people aren't taking what has been prescribed to them, or the medication has been stopped by one of their medical team and that information doesn't get conveyed to the pharmacy, which is more often than not. Even in our EMR where it says it was sent and confirmed receipt by the pharmacy, they don't get it when you stop a medicine.
Yeah, I do think that we also have, we have pharmacist personnel in the ER that helps with the med reconciliations and on the floors as well. But I do agree with Dr. Drost, it's a mixture. And sometimes it's really hard to find out exactly what the patient takes, because I'm always looking for who helps the patient with the medications, or who sets up the pill box. But, you know, the person, what the patient takes is oftentimes does not match what the pharmacy sent. So it's important to also talk with the patient as well. I would say more often than not, it doesn't match.
Right.
I would like to comment on that. I'm sorry, on that clinical. Somebody said that there's a clinical pharmacist in the ED. Does that mean that once a patient is in the ER, that they would contact the pharmacy?
So, so we do have a clinical pharmacist in the emergency room that is helping to do a lot of different things. They help with decisions on medications in general, but then also to make sure that the medications from home are clarified. So trying to, and I know here at Summa, we do more of that on the floor. We do have that clinical pharmacist, but he gets it started and then we finish it up on the floor. But at a lot of hospitals, they do have pharmacy technicians there as well. So their role isn't really to dispense the medication, but to just basically help with dosing, and then also the techs will call the pharmacies. And there are some services that are available. You can get a list of what has recently been dispensed for a pharmacist. So I know that's a program that someone has recently made that helps us as well. Although it isn't always 100% accurate, it does give us a good idea.
Okay, thank you. Well, I just wanted to add that on top of the medication list, you also need to put down the allergies to certain medications, allergies to food and environmental allergies also.
Yeah, absolutely, because those change over time. So making sure those are all up to date is also very important.
Annette also points out, she feels like depression is overlooked a lot due to the focus on physical issues, and that maybe if depression was addressed, there wouldn't be as many physical issues. So that's a good point. Mark comments that OTC meds are often left off the list when asking patients and family what they're taking. So he's learned to ask specifically if they're taking any OTC meds or supplements. Sue, I know you're saying yay. I don't know if you want to comment on it.
No, that's absolutely right, is that if you don't ask, most people won't tell you OTCs are herbal. So it's important to ask those things. And a lot of times you think OTCs are safe and aren't the reason for admission, but sometimes they're contributing to admission, especially in our older patients.
Michelle points out that it can be a challenge if a home medication isn't carried by the hospital pharmacy and has to be brought from home, which can result in a delay and or giving a different medication while they're in the patient, which can be confusing.
Yeah, hospitals
then-
have
Go ahead.
definitely formularies, which you can speak more to, but that can, right, if the medication isn't on formulary there at the hospital, most of those, most will have therapeutic interchanges. So a medication that will perform the same job, but I agree particularly on that medication reconciliation, both the, admission and discharge, really identifying if there's a good reason for that person to switch medications, or if they can resume their previous, home medicine, they were on an incontinence medicine or something like that, that it would be appropriate to continue at home versus, they changed their water pill, that was probably for a reason.
Yeah, we actually had a situation in my family where my dad was on a medication that was not in the hospital formulary and had to bring it from home. And then we're faced with pretty significant charges for administering his own medication. So that was interesting.
Yeah.
Go
Definitely
ahead.
the computer systems have gotten better over the years to make it easier to do those interchanges. It is almost impossible to carry every medication. There's just so many medications that it is very difficult to carry everything that somebody be on. But at least now the hospital computer systems don't set up for you to send somebody home on that same medication that you changed it to, instead to go back to the original.
And it also points out that they're a trauma center. So, all of these resources with the techs and the pharmacists help decide meds quickly. And Kristen points out that updating the patient and family on the daily plan and expectations can increase compliance and engagement in the plan of care. Definitely agree with that. And then Patty says it's also very important to reconcile medication after hospital discharge. We used to find many discrepancies in our primary care practice after discharge.
It's one of my just and I'm thankful and happy that my patients and families trust me and my opinion. But it's one of those things where, kind of like you just want to shake them. You were in the hospital for a heart failure exacerbation, and you're not going to take any of your new heart medicines until you're seen for a follow-up. And you were discharged on Friday, and we have an appointment on Tuesday.
Not to change the subject, but we were talking about nutrition. And my husband was a case where he had so many issues, including dementia. And he really basically lived on Ensure, oatmeal, and yogurt and applesauce. And that issue was never brought up. Whenever he was hospitalized, I always told the people when he got on the floor that I needed to have a consultation with the nutritionist. And I know more than once, somehow or other, it got into his record that he weighed 150 pounds and he weighed 111. And the nutritionist would come up and say to me, you know, why do you need a consult? He weighs 150 pounds. And I would tell them, look at him. He does not weigh 150 pounds. And this is what he needs to eat. And if I hadn't been there and no one else in the family had been there, he would have been brought a regular diet 3 times a day. And he would probably have drunk the liquid, and that would have been all he would eat. And I really feel that nutrition was a very important aspect of his care, and it seemed to be taken rather lightly.
Maureen comments similarly, having one family member as a contact/decision helper can also reduce confusion for the patient. So.
It's definitely important to have an advocate for individuals who are in the hospital. And I would say, you know, regardless of if that person is older or younger, having, you know, a trusted person that can share in the information, right, that can help to gather, that can advocate, that can be another voice for the individual that's sick is very important.
This is Dima Esper. I just wanted to add something along the lines of what Nancy was saying. I totally agree with you on obviously the role of nutrition in older adults. I just think the dietary guidelines just came out and talked about how we need to look at nutrition as a whole lifespan, and it's not just something we address when a concern comes up. And there's so many entities to why this is being missed in our system and why it's not looked at as a preventive, but rather in management and support of disease and conditions. And I think it's because it's not valued, unfortunately, based off of resources, you know. And when you do go to the hospital, you get screened for nutrition risk. But again, if you don't meet these check marks, then that doesn't alert someone to come up and, you know, get a full assessment. So I think screening is a really big entity in addressing and picking up for possible risk for a comprehensive assessment by the registered dietitian nutritionist who can do a more comprehensive assessment. But I think with the multi-poly medications, chronic disease, like you said, many oral and dental manifestations that come up and make it difficult to eat. The disease process itself changes organ function, changes absorption, digestion. I mean, there are just so many entities, but I think having more of a skilled person, maybe the person who came up was more of an aid, maybe somebody who was addressing more from that standpoint than the person who needed to do more of a comprehensive assessment, who could have done a bedside evaluation to evaluate your husband for malnutrition and do a physical exam. And so I think there's just a lot of education. I just read a paper today about it's one of the things that is lacking in professional health professions is the role of nutrition in prevention, management, and just continuing health altogether. And I think having these multi opportunities for people to bring up, you know, specialties and what we can do to help in that puzzle piece is always appreciated. So I hope you value that. I don't mean to interrupt your presentation, but I think it's more conversations like this and bringing more health professions together to understand what piece you can play in this puzzle and valuing those expertise. And I think, unfortunately, in our profession, it's been overlooked. And I know in medical education, it's overlooked. You know, there's just so many ways it's not integrated. And I think medical system is not set up for an automatic evaluation of it, because it, again, is a consultation expert. It's a consultation when you get in the medical, you know, get into the hospital systems, you have to be consulted. Like, that shouldn't be a consultation. That should be just be standard practice. But I hope these kinds of interactions are helping to expand our appreciation for what everyone can do to support health outcomes in a positive way.
So your point is well taken. For those of us who've been involved with GWEP for a while, we will back you up on that idea of bringing people together. And we have definitely our own team. We do a lot of interprofessional educations. We do simulated team trainings, etc. And we always include nutrition, always, always, always. So we definitely are in agreement that more conversations, you know, the more integrated the various professions are, the absolute better patient outcomes. So thanks.
I can soapbox about the importance of nutrition and how our mainstream nutritional stuff is a bit skewed by a lot of history and political input. So definitely important. And when you look at the numbers, right, if 40% of older adults that coming into the hospital are malnourished, then, you know, you should screen everybody, because you have a 50-50 chance of hitting somebody who is, right? And then you put in the risk of being in the hospital with an acute illness and how that affects nutrition. It's just, yes, it should be a mandatory referral.
It should be more available outpatient too. It's so hard to find a dietitian to see outpatient. There's so few that are doing that anymore. I don't know whether it's a payment issue or why, but I've ran into that. Definitely, that's hard to get. At least we can consult a dietitian in the hospital, but you're right. It would be better if it was, the screenings were a little bit looser on who they see.
Maggie points out Medicare should cover dentists hard to eat with problem teeth. Wholeheartedly agree.
Yes. Yeah. Yes. Again, can soapbox on all types of topics, but you know, if we even are looking at, you know, our definition of health, if you look at the World Health Organization definition on like health, and if our healthcare system is supposed to be maintaining health, which should be more affordable and cost effective and keep people active and engaged and healthy and you know, part of the I would say productive society, but that's not just working, that's, you know, doing things you enjoy doing and beautifying the world and gardening and all of that kind of stuff. You know, all of these things, nutrition, dental care, or oral health care is actually oral health care. It's more than just your teeth and your dentist. You know, support for pharmacy, support for our whole team in doing this is key. So, okay, great discussion. Thank you, everybody. So the last couple slides here, we're looking at a few evidence-based transit care plans or models of care in the hospital specifically that look to address this. One is the acute care for the elderly, or ACE units. And those really are created to prepare an environment that promotes mobility and orientation. It is team-based. They do team-based rounds every day to identify individuals that are high risk and really to work to create a patient-centered care plan. With that goal of early discharge, we learned about all of the bad things that can happen to an individual in the hospital. And so from the start of their hospitalization, we want to be thinking about what's the discharge plan for this person? Where are they going? How do we support them? Hopefully in the least restrictive environment as possible, meaning if they don't have to go to a nursing home, even for rehab, They don't, meaning they can go home with increased supports, and a high look at those medication issues. And then the hospital elder life program or help program is designed specifically and evaluated to look at reducing and preventing delirium. Interventions are interprofessional, kind of focal that look at those key 6 delirium risk factors, which we mentioned before. So identifying those with baseline cognitive impairment, identifying sleep intervention or sleep deprivation, immobility, visual and hearing impairment, and that risk for dehydration. It does focus a lot on volunteers that are there to provide not only aid and companionship, but also to get people up and walking sooner and farther in their hospitalization. And they have been identified, it has been shown to prevent about 1/3 of delirium cases. The IHI has created the Age-Friendly Health Systems Initiative, and it identifies these 4 key factors they call the 4 M's of caring for older adults, where we identify what matters in an ongoing fashion. So it's much more than just like goals of care. Do you want CPR, not want CPR, but really what are the things that individual values most in their healthcare, and how do we optimize their care, looking at their medications, looking at their mentation, cognition and depression, delirium types of things, optimizing their mobility to help them to meet those goals of what matters most, and taking away, hopefully, the things that we sometimes do to people that don't necessarily help them meet those goals. And then at discharge, again, we've talked about most of these things, but making sure we're looking at the discharge environment, what types of equipment or durable medical supplies do they need, hopefully at home, to keep them more independent. Is this canes or walkers, a hospital bed, a bedside commode? How do we think through those things at the time of discharge? How do we get family or community members involved in their care? And what types of in-home services or community-based organizations can we pull in that, again, help to support that individual at home? Coordination with primary care is key for follow-up, but then also any of those other specialists or follow-up appointments that are needed. Harping on the medication reconciliation, again, at discharge is key, and making sure that people understand where and when and why things have been changed to their medication lists. Thinking about transportation, whether that's home from the hospital or to those follow-up appointments to get blood work done, to get repeat testing done, and ongoing education about new or worsening illnesses that they can work to manage. And then where do they get discharged to? Can help to decide what some of those next plans are. And this is just kind of a list of potential discharging locations. And lastly, there are, and as we look at transitional care, so that period after hospitalization, typically 30 days, sometimes 60 or 90, depending on the model. But there are lots of different models of care that have been established in an evidence-based fashion that prevent readmission rates. And the key to most of these they are social work or nursing led. So there is a care manager who helps to facilitate that. They establish and maintain that relationship and help to coordinate care. They're engaging the patient and family in that chronic disease or chronic illness management, and providing education and ongoing support for that individual to continue to self-navigate or to learn to self-navigate and to continue that within the health system, and looking at those symptoms that the individual may have. All right. Other questions, thoughts, comments? Thank you for all the comments so far. It's definitely an thoughtful and engaged group.
One of the things I wonder if you could talk about a little bit more is the care transition. I'm looking at Lori too. I don't know if she wanted to talk about anything through the area agency, but I mean, like, how would some insurance companies set you up with a discharge, transition care manager, et cetera? How would people get access, I guess, to those types of transitional care services?
You know, I'm not familiar with how that would work on the insurance side of things. I know the medical staff can make those referrals to the area agency, and we can get the ball rolling there, start connecting the person getting discharged to their family with those coordinators that are able to provide those services. So absolutely, we can get that started that way. But I can find out about insurance, but I can't accurately speak to that one.
That's fine.
There's a lot of variability between insurance companies, especially if we're talking about older adults who are primarily using Medicare. So if you have traditional Medicare, that may be a little bit more limited what some of those transitional care resources might be through your insurance. But if you have a managed care or an Advantage Medicare plan, like an Aetna, Humana, MMO, Summa Care, Blue Cross, Blue Shield, like on and on, right? If you have one of those plans, you're right, a lot of those do have a transitional care manager who will do telephonic care management. So they'll call after discharge, follow up with you, make sure you've gotten your medications, make sure you are encouraging and providing some support to make to go to your follow-up appointments, making sure that you've had at least your primary care follow-up visit, and providing some disease education about self-management goals and that. So heart failure, checking your weights, checking your blood pressures, diabetes, your blood sugar monitoring, all of those sorts of things. And that's usually initiated by the insurance company themselves. They've flagged that hospitalization and that kind of chief diagnosis in order to establish that, and probably targeting the most common and high risk reasons for admission, which includes heart failure, COPD, pneumonia, those types of things.
We have a comment. Agree that med reconciliation is important. Works in home care. So many of their clients don't know why they're on certain medications. Spends most of their time trying to explain, but they're a social worker, not a nurse. So
yeah, this ties back into, I think, Maggie, you made the comment about like why you're taking a medication, to include that on that medication list, and to ask, if you so we want an accurate and up-to-date medication list, and an indication for that. So kind of that point that sometimes we're using medications for one thing and not another thing. So working with your primary care or the physician in the hospital to really kind of pin down, am I on a blood thinner? Did I have a blood clot, or is this preventative because I have atrial fibrillation or irregular heartbeat? Like help me with that. Or is it both? Am I on, there's lots of medications that we use for heart disease, but they're also blood pressure medications. So am I on it just for my blood pressure, or do I also have heart failure? And trying to tease those out and including that on the list, I think not only helps that individual know their medication list and the indications, like Victor's comment is, better, but then also helps that team going forward. And I'd say along that too, if it might not be an allergy per se, but if you've been on a medication for something and it didn't work well for you for one reason or another, that might not be an allergy, but you could include that as notes down in there somewhere. That says I tried this antidepressant and it really didn't work out well for me. It didn't treat my symptoms or made things worse or whatever. It's not an actual allergy, but it's a reason not to perhaps prescribe that again in the future.
I just want to piggyback on what you said, because I was in ER actually twice in less than a month, and they were asking me, why are you allergic to this medication? What happens when you take it? See, that sometimes it's been a long time ago, and I don't remember. Did I have rash, or did I throw up, or what happened? So that alerted me to the fact that next time this happens, I need to make note of what happened when I took this particular medication that I was taken off. Like, for example, I was taking amoxicillin for my dental implant, and I developed like red spots on my legs. So, you know, it's just an alert to keep those in mind, because they do ask those questions to the hospital and the doctor's office.
Yeah, Annette points out, so that's a good tip. Says as she gets older, she forgets what meds she's had 20 years ago when she had surgery, and she thought to herself she's a bad historian, and she's a nurse. So
It's so complicated to kind of think through those things for sure. And the allergies, right? I mean, and you know, we hear that as we ask people, you know, what medicines are you taking? You know, part of that's trying to get some of that history. And part of that's assessing kind of individuals' understanding of what they're taking and why they're taking it. So as we're asking those questions, similar things with allergies, you know, and getting that response. Well, it's in my medical record. Well, it is, but you know, things slip into the medical record too that aren't accurate. You know, when we're asking and clarifying those, there's multiple reasons for getting at that information too. There are questions? All right. Well, thank you guys.
Alrighty, well, we can go ahead and sign off. Everybody, thanks for being here, and hope you know, the idea of this is to give you sort of the highlights of the major issues in this particular environment, the hospital, acute care, and then that transition. What are the major things you need to think about and are of concern? So we're sort of trying to capture a lot of different areas where geriatric, you know, you'll find geriatric concerns. So this is one of them. We'll get to hospice. We had area agency, et cetera. So, all right. Thank you all.